Hello everyone, thank you for being here today. I'm Zeena and I'm happy to talk to you a little bit about our work on assessing the sensitivity of brain age to Alzheimer's disease in different ethnic groups. Oh, okay. Sorry. That's all right. So, Alzheimer's is the most common neurodegenerative disease and cause of dementia, as you've already heard in this session. And unfortunately, the global burden is growing, with 152 million people projected to have dementia by 2050. And the number of people living with dementia is estimated to rise particularly in low and middle income countries. Despite this, there's a lack of literature examining the potential impact of ethnic and racial factors on research outputs. And there's quite a few research outputs. One of them that you may have heard of before, sorry, the animations are a bit out of whack, is brain age, which is a useful index of brain health and is predictive of dementia. Brain age can be derived in several ways, but in this case, we'll be talking about brain age derived from routinely collected T1 MRI scans. And when trying to find someone's brain age, the first step is to pre-process your data. This involves segmenting and normalizing your images. Then you perform quality control, convert them to vectors, and then mask gray matter, white matter, and CSF, and combine these together. Once you have that, you use your model, which has been trained on healthy brain age data. It's been trained on the T1 structural MRI scans and people's chronological age. And you input your test data into this model. And you get a predicted or estimated brain age. Now, an important metric in brain age is known as the brain PAD, or the brain predicted age difference. This is the only abbreviation I'm going to mention, so you don't need to remember any others. But this is the difference between the estimated age and someone's chronological age. And if we look at the figure on the right, you can see a plot of chronological age against estimated brain age. The x equals y line would correspond to a perfect prediction, and then the green line underneath that is delayed aging, the orange line above is advanced aging, and the red line accelerated aging. We would expect someone with Alzheimer's disease, because of the thinning in their brain, to be in that orange-red zone. And brain age is correlated with increased risk of dementia in observational research cohorts and memory clinic patients. It can help identify mild cognitive impairment to Alzheimer's conversion, has the potential to aid in early dementia diagnosis, and can help identify high-risk patients for clinical trial stratification. Importantly, because it's derived from routinely collected MRI scans, it would be very easy to integrate into electronic healthcare records to aid in prognosis. However, brain age models, or many of them, are trained on predominantly white data sets. So before being able to implement them in clinic, we would need to know if they're generalizable. In our research, we specifically looked at BrainAger. It's an open access software. If you look it up on Google, on GitHub, it's available. And it was trained on a predominantly white, non-diverse cohort of 3,377 individuals from 7 public data sets. So our overall aim was to investigate the sensitivity and generalizability of brain age in non-white individuals. And to do this, we age and sex matched individuals from the National Alzheimer's Coordinating Center dataset, which has 23 sites in total. These are based in the US. And after filtering, we found 389 cognitive controls, and in this case, by controls, we mean individuals who have no cognitive impairment, and 189 patients living with AD. The breakdown of the non-white group is as follows. We had 68% of individuals being Black or African American, 20% multiracial, 8% Asian, 4% American Indian or Alaska Native, and lastly, less than 1% were Native Hawaiian or other Pacific Islander. To answer our overall aim, we broke it down into 2 questions. So for our first question, we looked at the sensitivity. So we wanted to answer whether there's a significant brain predicted age difference between controls and Alzheimer's in both the non-white and white groups. And our second question looked at generalizability, specifically whether ethnic group affects the relationship between chronological age and brain predicted age in controls and in Alzheimer's. And to answer these questions, we used the Welch two-sample t-test and a Cohen's d effect size, as well as a regression analysis. So we found that the mean brain pad was significantly different between the control and Alzheimer's groups. So here we can see box plots with the left panel showing the non-white group and the white panel showing the white groups. In both cases, the Alzheimer's groups have a higher brain predicted age difference. This is as expected because of cortical thinning in the brain. Although there is a slight difference in the effect sizes, with the effect size of Alzheimer's disease on brain pad being slightly weaker in the non-white group, though still significantly greater than 0. With regards to our second question, we found that linear regression showed no evidence of ethnic differences in model fitting in controls. So in this case, we have real age on the x-axis and the brain predicted age on the y-axis. We fit linear regression lines to both non-white controls and white controls. The dashed red line in the middle is the x equals y, so if you had a perfect prediction, it would be there. In both cases, the R-squared values are quite high. The lines are quite close to the x equals y line, which is as expected because these are controls. However, in the case of Alzheimer's, our results are a bit more inconclusive. We do see that the R-squared values are lower, again, because of the neurodegeneration in the different regions of the brain. This is expected, but the difference between the two non-white groups is larger than the ones in the white groups. So further analysis is required. So in summary, with regards to the first question of sensitivity, we found that there was a significant brain predicted age difference between controls and Alzheimer's in both the non-white and white groups. And we found that ethnic groups did not affect the relationship between chronological age and brain predicted age in controls, but had inconclusive results for Alzheimer's disease. So more work is required to demonstrate and improve the generalizability in further demographic groups, and our plan is to actually look at larger data sets with significant numbers in specific ethnicities in order to evaluate this brain age method and potentially other brain age methods as well. In conclusion, we showed that a brain age model trained on a less diverse data set generalized similarly to white and non-white controls and was partially robust to Alzheimer's when tested in a sample of different ethnicity. So essentially, if you have a good reference data set, and there are ways to account and control for differences because of biases in your training data set. Many methods, including brain age, are based on non-representative data, yet these methods do have the potential to impact patient care. So it is important, where we can, to include underrepresented groups, but otherwise we can also show, we can evaluate the impact of ethnicity within training data sets to prevent furthering pre-existing inequalities. Thank you very much for listening, and to everyone involved.
Great, thank you for an excellent talk. There's a number of questions here. The first starts with great talk, and follows up with, as the NACC data set is very large, could you comment on how you got to the final smaller sample sizes?
So the sample sizes were based off of individuals that had T1 MRI scans, individuals that were not cognitively impaired for the controls, and that were diagnosed specifically for Alzheimer's in the Alzheimer's group. If it's okay, can I go back to my slides? I have a few notes.
Yeah, sure.
That question. Oh, maybe I physically cannot go back to my slides.
The red button will take you backwards on the remote control.
Oh, cool. Apologies. It's not the most efficient way of doing it.
Yeah, sorry.
Can we not scroll on the tablet?
I don't think so. I don't know. Maybe.
Okay, sorry. Well, that's kind of like the main way that the numbers dwindle down to these groups. And also, because of the number of individuals that were in the non-white group, there's not that many after you do all those reductions. So because we age and sex match, the numbers greatly reduced. Yeah.
Okay. This one that got upweighted, this is an interesting question. How do you evaluate the variability of a diverse group, non-white or otherwise, as a potential driver of the kind of inconclusiveness you have in your conclusions?
Definitely, we have thought of that. So because our non-white group is actually composed of many ethnicities, and there is research to show that there's a different pattern of neurodegeneration, potentially in Alzheimer's in these specific groups, that it could affect our results and the spread. How do we go? I'm trying to click through. I have a few plots showing the Is the green button for next?
Green button's for next, yeah.
Okay. It's not working. Okay, well, I did plot scatter plots and box plots with these specific subgroups of the non-white ethnicities, and there doesn't seem to be a specific trend, but again, because the sample sizes are quite low, especially when you get to the smaller groups, we would need further data to evaluate, and that's why we plan on looking at larger data sets like the HABS HD. Yeah.
So I think a good follow-up question of that, and this is actually a question I had when I was watching your talk, was did you investigate ethnicity differences in the effects using an interaction, and that way you're comparing group to group instead of these kind of qualitative differences in the statistics that you're looking at right now?
No, we haven't, and that's a great point. So
I mean, it's doable with the data you have, I think, right?
Yeah. So I guess that's one of the things we'll be doing next, for sure. Thank you.
Great. That's why you go to a conference.
Yeah.
All right. Thank you very much for a lovely talk.
Thank you.